okay, I'm going to talk about febrile neutropenia. Also, I have to apologize sometimes for, my English is not my native language either, but I think it will be okay and you can understand me. If not anything, please feel free to stop me or to ask or whatever. So this is supported by the Blood SA Foundation, by this platform, which is really a great platform, as I have seen in these days, the BMT management team. And just some reminders that this is recorded, that feel free to interact and in the chat box or whatever. And also you have the CPD points that it's really great to be able to build up your curriculum, no? Also WhatsApp group that you have built so lovely among the South African nurses. So this is great where you can, contact each other and keep building up the group. So these are going to be the key points. An introduction about neutropenia, febrile neutropenia, risk factors, etiology, timeline of infections, management, treatment, nurse management, protective measures, and sepsis. So at first we have, as we all know, in our body, and we have our natural barriers. So these are going to be skin and mucosa. If we have them integrity, we don't have no breakage, that these are going to be natural barriers for infections. We have our immune system with the lymphocytes B, T, monocytes, that these lymphocytes, for example, the B, they are going to produce antibodies against the bacteria, virus, etc. And we have the T cells that are going to attack a virus, right? And then we also have the monocytes, that these are going to be macrophages, that they are going also to present antigens to the lymphocytes, so they can attack also virus and also cancer cells. And then we have in the first line, we have neutrophils, that this is really the first line of that is going to protect us. And they are the first line of defense, and they are going to go against bacterial and fungal infections. On the right side of the slide, you can see which is normal cell counts of these that we have presented. So we have the leukocytes. In this case, I've put this numbers, but it's okay. We can say like 4.0 per 10 elevated at 3 liters, or we can say like 4,000 per microliter. So we can understand both of the measurements. It's equivalent. And neutrophils, we would say 2.5 or 2,500 would be the normal counts above this per microliter. And lymphocytes would be above 1,500 per microliter, and monocytes would be 200 per microliter. Above that would be the normal blood counts of our white blood cells. These are what the counts that we need to be protected. Okay, so now I'm just going to point this video. It's a very short video, but I think it's very visual of how a neutrophil works and how it wonderfully protects us from infections.
Neutrophils are white blood cells that hunt and kill bacteria. In this spread, a neutrophil is seen in the midst of red blood cells. Staphylococcus aureus bacteria have been added. The small clump of bacteria release a chemoattractant that is sensed by the neutrophil. The neutrophil becomes polarized and starts chasing the bacteria. The bacteria, bounced around by thermal energy, move in a random path, seeming to avoid their predator. Eventually, the neutrophil catches up with the bacteria and engulfs them by phagocytosis.
So as you have seen, I think this is really very visual, and it helps us to make the idea of how neutrophils work and how they, go after that bacteria and try also to defend us. So this is why it's so important to have our levels. But this doesn't always happen, as we all know as hematology nurses and transplant nurses. So febrile neutropenia is a critical condition involving fever more than 38 degrees Celsius and a low neutrophil count, which makes patients highly vulnerable to bacterial, viral, and fungal infections. What do we call neutropenia? When neutropenia is when the neutrophil count is below 500 neutrophils per milliliter. And also are going to say neutropenia when we are talking about neutrophil counts below 1,000 neutrophils per milliliter with an expected decrease in the next 24 or 48 hours below 500. That this is usually what maybe could happen or what will happen in our transplanted patients. Fever is a single register of axillary temperature more than 38 grades Celsius degrees, and or could be also two measurements more than 37.8 separately or maintained for at least 1 hour. As you can see here, we have the common terminology criteria for adverse events. This is focused on hematological adverse events. So if you see on this, I don't know if you can see my pointer, but well, if you go to the first, second, third, fourth line, we see neutropenia. So we are going to see here how are we going to grade the level of neutropenia. So we are going to have grade 1 when we have it below the lower limit of normal, 1,500 per milliliter. It will be grade 2 when it's less than 1,500 or 1,000 per milliliter. We will have grade 3 when it's less than 1,000 to 500 milliliters, and we will have grade 4 when it's less than 500 milliliters. So, and as you can see on the next line there below neutropenia, where it says febrile neutropenia, as you can see on the last grade 4, this is already, they determine it like life-threatening. So we have two concepts here, and mostly in our patients, as we are going to see on the next slide when we see a timeline of the transplant, is that we have myelosuppression. There is going to be a decrease in blood cell production, and we have an immune response that doesn't cover what we need. There are going to be decrease of neutrophils, and we know that also neutrophils are responsible for some clinical signs and symptoms during bacterial infection. So when we have to diagnose the infection, maybe sometimes it's going to be more difficult because we are not going to have, for example, an abscess, or maybe the aspect of the central line is not bad because we don't have those neutrophils that are working on that side, on that wound, or on that central line or wherever to be protecting us. And that's what, when we have like a worse aspect, or we have an abscess, where we can see other signs and symptoms. So the timeline of a transplant is this. We have on day 0, we have the infusion of the hematopoietic stem cell, the hematopoietic stem cells. The day 0 would be the infusion. And we have this aplasia phase until approximately day +10. Here, it's happens what we have said in the previous slides, myelosuppression, and we don't have all the immune response. When we go after day +10, we are going to find after the engraftment phase. This engraftment phase is going to be different depending on the type of transplant. We will have an earlier engraftment when we have an autologous transplant, and then we have a later engraftment when we are talking about an allogenic transplant. Although we also are going to find differences when we use different sources for the transplant. So if we are using a peripheral blood, the source of a peripheral blood, the engraftment would be earlier. If we are using bone marrow, it will be a bit delayed. And if we are finally using cord blood, because of the less cells that you can find in the cord blood, the engraftment phase will be more delayed. So which are the risk factors that we have for febrile neutropenia and transplant. The first will be in the pre-transplant, and mostly here we are going to have the conditioning regimen. We know that the conditioning regimen, what is going to be the risk factor is myeloablative conditioning, of course, because this is going to produce the most myelosuppression of our patient. Also, and when we have the allogenic transplant, that this is something that doesn't happen in the autologous, we have to use immunosuppressive treatments to avoid graft versus host disease, such as cyclosporine or corticosteroids or different medications that we are going to use as the immunosuppressive. So this is also going to make our patients more myelosuppressed. In the post-transplant, we have to wait, or the risk factor would be until when we get the recovery of the bone marrow, what we had talked before about the engraftment. And then we can find that sometimes there is going to be a prolonged neutropenia. This is going to be a severe neutropenia because if it's prolonged among the weeks, then we are at a major risk for any infection or febrile neutropenia. Around the etiology, we are going to find for the bacterial infections, this is going to be produced by gram-positive, by, as you see there, Staphylococcus aureus, Streptococcus pneumonia, among others, gram-negatives, Pseudomonas, Escherichia coli, among others, of course, also. Viral infections that will be produced by herpes virus, as you see here, for example, by varicella zoster, cytomegalovirus, herpes simplex. We also have respiratory virus like influenza, the respiratory syncytial virus, RSV, and others such as adenovirus or Epstein-Barr. And the functional infections will be produced by aspergillosis or candidiasis, among maybe others that can also be present. This is a timeline of the infections that could occur in our transplanted patients. I think a lot of you probably do know this this slide or this presentation because it has been already published in several places. But it's a very visual and where you can see how the infections are changed during the phases of transplant. So when we have in the phase 1, the pre-engraftment, well, it's divided in pre-engraftment, post-engraftment, and the late phase, no? And you see also on the second line, it talks about graft versus host disease because in the first phase you have the acute graft versus host disease. At some time in the second phase, you can have you can have an overlap of acute and chronic, and then you can continue probably having only chronic or maybe no GVHD. That would be the best for our patients, of course. Among these, in the phase 1, in the pre-engraftment, where we are going to find the neutropenia, we have barrier breakdown because of the mucositis, or because we also have, for example, the central line inserted in the patient because he is having his transplant. He is in the surroundings of the process of the transplant in the ward. So what is more probable to have here in this phase is more probable to have a bacterial infection produced by gram-negative or gram-positive, or also the endogenous gastrointestinal flora. These are mainly gram-negative, so these can produce infections. And because of the central lines, mostly these we are going to have infections based on gram-positives, such as, for example, Staphylococcus, right? You can also have some types of virus, although they are less common in this first phase. And of course, you can have fungal infections. In the second phase, the post-engraftment, you have the first recovery are going to be the NK cells. These are cells that are going to rapid detect a virus. So they are going to be very active for the virus and the tumor cells that they will kill them. And what we do have are that the T cells that also are active against virus, and we have the antibodies of the lymphocytes B, these are still going to be increasing, but slowly. So we are still at risk for some of bacterial infections, virus infections, and fungal infections. And as you see in the slide, in the slide, you can see that when the color is in blue, and then if you have a bigger box, you have more risk for this types of infection, right? And in the end, when you are talking about more, we are talking more about day 100 and over. You can have, we are the B cells and the T cells are continuing to recover, but also over here we have already some vaccination, so the patient will be a little bit more protected against some of the infections. Although we will still have encapsulated bacteria there, very also the zoster virus, and also fungal infections at a risk. So how do we manage febrile neutropenia? Well, it's very important to have the medical history, a good clinical exam to check for any possible of infection. We have to check, or together with the physicians, no, I will focus later a little bit more on the nurse management, but here everyone has to know to focus and see about the central lines, if it has any bad aspect or if it's okay, any skin breakage, lesion in the perianal zone, if there is any abscess, or if there is anything that we see that is not correct there. Also, abdominal pain. Check if the patient is saying that he has pain, diarrhea, if there are any symptoms of the respiratory tract. See if there are any signs or symptoms around the central nervous system, or if the patient is discussing or is complaining about any chest pain. So these are all the signs and symptoms that we must seek for, look for, see if the patient has any comorbidities, check for in which day of the treatment, on which day of the transplant, at what point the patient is. We should check all the vital signs: temperature, heart rate, respiratory rate, blood pressure, oxygen saturation, and fluid balance. As tests, what is very important for us to do? These are the blood culture of the central line lumens of all of them, if it's possible, and also we should do the peripheral cultures also of the peripheral veins. This is going to help us to test if which is the origin of the infection. Also, blood tests as asked for, and if sepsis is suspected, we should determine lactate and CRP. Also, urine, sputum culture, and any other suspicious focus cultures should be done if there is any, as we said before, any wound or the catheter doesn't have a good aspect. And also the chest X-ray if the patient has been complaining of any difficulty and respiratory difficulty. Treatment of the febrile neutropenia, we will have to administer antibiotics. Antibiotics according to the center guidelines. We will see some of these in the next slides. Colony stimulating factors, and of course we should continuously monitor vital signs, that these are going to alert us if there is any problem. So now I have a question for you, and I don't know if you want to okay, this is treatment will begin after blood cultures have been taken and within the hours of the onset of fever. When should the treatment begin? It's an open question. Just if you want to write it, or if someone wants to say it out loud or whatever. I think you know it. You all know it. Okay, so here's the answer. The first hour. It's really important to start the treatment in the first hour of the onset of fever. This is going to help us to prevent to have a worse or instability of our patient, and to maybe escalate to, for example, sepsis. But we will see this in the next slides. And this is taken like the golden hour that everyone talks. No, it's that any patient with febrile neutropenia, it's important to, as soon as possible, do the cultures and start with the treatment as soon as possible. What treatments do we have? And basically, I mean, here I'm going to explain which is our local guidelines, but I think that these are very like sort of general for everyone, more or less. If not, you have to stick to your local guidelines. But usually, is we start with, for example, cefepime. These are going to be for gram-positive bacteria, and piperacillin tazobactam. These are going to have a broad range of gram-positive and gram-negative bacteria, including several strains resistant to aminoglycosides and third-generation cephalosporins. This is very important because, as we will see in the next slide, just a few words about the multi-drug resistant bacteria, and this is really important to keep it in mind because it's a difficult issue in healthcare nowadays. The next, what we would do if we have an anaerobic infection, or we have already discovered by the cultures, or there is a suspicion of anaerobic infection or hemodynamic instability, or we have the peritoneal colonized by multi-resistant bacteria, we are going to administer meropenem. If fever persists after 48 hours, or the patient is hemodynamic instability, we will add vancomycin to ensure greater coverage against gram-positive bacteria. If gram-negative infection is suspected, we will add amikacin. And if on the 5th day of fever, the patient still hasn't recovered and the fever hasn't gone down and still remains neutropenic, he has had a risk for fungal infection, so the treatment would be added. We would have to add liposomal amphotericin B or caspofungin. If we have an underlying disease, such as a solid tumor or high-risk leukemia, and or the patient is at a complete remission, growth factors could be also administered to help to go out of that neutropenia phase. Just a few words about the multi-drug resistant. These are the bacteria that resist 3 or more classes of antibiotics, and this is really a challenge for, as we said, in our healthcare. We have these: the MRSA, the resistant Staphylococcus aureus, the FVRE, vancomycin resistant Enterococcus, Carbanet resistant Enterobacteria, and Carbanem resistant Acinetobacter baumannii. And these are really difficult to manage, although luckily there are some of the antibiotics that we have said in the slide before. They are useful for some of these, so this is good news. But it's true that we have to, and the physicians have, together with the infection specialists, have to do the appropriate choice and duration of the antibiotics, do these strategies well, so we don't lose the last antibiotics, the last generation, that if not, we are not going to have these antibiotics needed to go against the infections that are going to be appearing along the time in our patients. It's important for us to know that they spread person to person contact, and also by contaminated surfaces, contaminated food and water. So we have to think about this. We have to try not to spread or cut this chain so that there will not
Julia,
yes.
Sorry to interject. May I ask the guests please to mute themselves and switch off the cameras as well, please. Pamela, Thomas, please, can you at least mute yourself and switch off your camera? Thank you. Thanks, Julia.
Okay, no worries. So I was saying, this is important for us as nurses also, because we are able to
Right.
keep the chain of spreading this, and we
So
know.
I want the code that we charge on the bully for top T.
Natasha, can you please unmute yourself, please? Please mute yourself, Natasha. Thank you.
Okay, I'll go on then. I wasn't sure if it was a question or whatever, but just in case, you let me know, please. So as I was saying, we are an important to cut this chain of spreading, so we can make sure that this doesn't go on, and also important the cleaning and using the decolonization and all the measures that we can use to stop this this chain of transmission. So what do we do, or what should we do as nurses? It's very important how we evaluate the patient. We have to check the vital signs, check temperature, check the condition of the patient, take care and check our central venous access, take the cultures as we have described before of all the lumens of the central line and peripheral veins. About the fever management, once there is fever, for the first we have to also control fever with antipyretics that have been prescribed by the physicians, and administrate, as we have said before, in the time of 1 hour before before 1 hour has passed of the onset of fever, of the broad spectrum antibiotics. So it's important for us also to, how can we prevent these infections? We have to check and protect the skin integrity. This is part of our nursing management. We have to help the patient to protect their skin, how to do their hygiene, how to do their oral care. And then there are some measures that are really important, that is hand hygiene. We will talk a little bit in the next slides, isolation precautions, and all around the personal hygiene and the environmental cleaning. We have to use the products, the adequate products, and also we are going to follow the local guidelines, because maybe it's different from one countries to others. But basically, most of the products are going to be chlorinated, derivated products, to be able to clean the surfaces, the walls, the floors of the rooms of the patients. And then monitoring, it's important to do a continuous monitoring of the vital signs, check for the fluid balance, and if any IV fluid support is needed, and if the patient is in need of any transfusion. An important part of nurses is also to assess pain. If the patient is with pain, we should assess and administrate analgesics as it's prescribed, and also the emotional support and the educational support, because here we have an important part also. We have to explain what's happening to the patient, to the family, explain them how do they have to take care, which are the signs, so they can tell the patients if they feel something different, if they feel worse. Also all about the precautions, about the hand hygiene, about how we should do isolation, what measures should we take. This is everything, and it's very important to educate patients and families to take care of all these things, in order to protect the patient. Then it's very important to have the multidisciplinary communication. This is a teamwork where all of us are together, and it's really needed to inform in an adequate way to the physicians, nurses, other nurses, nurse assistant, pharmacists, and any infectious specialists that can be working with us. And finally, we have to prevent complications. We have to continue monitoring, because for signs of sepsis, to avoid that this is going to escalate to a sepsis, and treat any or look for any side effects of the treatments that we are using or managing or administering. This is the most important thing I think, and actually, I think we all have had the experience in. We already know as nurses from always that this hand hygiene is the most important measure to avoid infections and to cut the chain of transmission and all this. But I think all the world was aware of this when the pandemic situation, so everyone learned a lot about this. So it's important to follow the guidelines of the World Health Organization of how is a good hand wash, how we should do the hand wash. It could be with soap and water, or we can use alcohol-based rub to do the hand rub. And also very important is the 5 moments. And as we all know, and I think it's very visual there in the slide that you can see in the hands, where you can see like the bacteria and everything, and how this could be passed from one side to another. So it's important to wash our hands or to do hand hygiene before getting to the patient, before doing any technique, after finishing any technique, also when we have finished, after touching any fluids or vomiting or anything of the patient, and finally after touching any of the surroundings of the patient of the room. So these are the 5 moments, very important to do this process of the hand hygiene, and I think everyone, all of us knows this for sure. What other protective measures do we use? And also mostly in transplanted patients, and when we have a febrile neutropenia, we use masks, hand hygiene that we have talked. Gloves are useful, but we have to also use them and know how to use them, because they can only be of a single use, and we can't go with the same gloves here, there, touch the door or wherever. So this is it's better a good hand hygiene than using gloves sometimes if they're not correctly used. And then as a recommendation, there is to have rooms with HEPA filters and positive pressure, or rooms with laminar airflow. It's true that it's a recommendation. This is not mandatory, and also, as it's said in the JC standards, but some type of filtered air, this is important. And of course, the cleaning, as we have said before, it's very important in the febrile neutropenia. And then reduced visits. And here, again, we have had already the education of the patients and the family, and it's important to tell them that we can't, when a patient is at a risk of infection, or we can't have we can't have no visits, or if the carer is going to change, let's try to see if the carer does not have any symptoms. It's important, or has not been vaccinated recently with with live virus, some of the vaccinations. So these are things that we have to explain to our patients and to the families and to the carers, because in the end it's all about protecting the patient from avoiding to escalate to any more complications. And now we have some words about sepsis. Sepsis, this is really the unrecognized killer, as it says here in the slide. And some signs of sepsis are tachycardia, tachypnea, hypotension, drowsiness, and confusion. It's very important to know which is the signs of the sepsis. And nurses are very important for screening sepsis, because if we need an early recognition and early intervention, we have to prevent the progression to worsening organ dysfunction, and we have to evaluate the condition and plan for disposition. This is really important, because if not, there is a point where the comeback is sometimes very difficult after sepsis. And here, what tools do we have, or what can help us to really prevent, or to have an early recognition? Well, nowadays we have these wonderful tools that are like early warning score. It's called EWS. And as you can see here, there are some physiological parameters and the scores on the top above. And we are going to check for the respiration rate, the saturation of oxygen, the air, if the patient is on air or on oxygen, blood pressure, pulse rate, consciousness, and temperature. So here we are going to combine, by combining each vital sign score, you're going to have us generate a score, and this is going to be the early warning score. It's classified in 3 clinical Trigar levels. It's going to be at low risk if it's from score 1 to 4, medium if it's from score 5 to 6, and high risk if it's 7 or more. Okay, so yeah, and if the score is more than 7, then we are at very high risk, and really it's we need intensive care, or we need emergency department, or we need something more. I put here just an example so we can together share and check the score that could be or could happen for this patient. So we go to the room of the patient, and we have a patient that has this as respiratory rate 23, as oxygen saturation of oxygen 95. The patient is on air. Blood pressure systolic is 100. Pulse rate is 112. The patient is alert, and the temperature of the patient is 36 grade Celsius. So take your time and give me a number. I don't know if you want to put just the number, give me the score on if you can on the chat, or if you want to just tell it out. I'll give you just like a few seconds or a minute just to think about what score would you have. I'll be happy if you put it in the chat, or if you want to just tell us out loud. Any way is okay with me. Do you have it? Okay, I'll wait for some more. And if not, we'll go through it together. Okay, let's go through it together. Yeah. Okay, I have score 8, but let's check, because some of you have already all put 7. So maybe there is some confusion on my side also. It could be, but it's I think it's an easy scale, and I think it's very useful for everyone to use it. No, it's a really nice tool. So the patient has respiratory rate 23. So if we go to the scale, we see that we would have 2. It will be 2 points, right? I'm going to put it down also, just in case. 2 points. We agree, right? Then on this oxygen saturation, I put here that it was 95 on the scale 1, that is this one. It's on the next line. So if we go to 95, it's on the yellow, and we find 94 to 95. So it would be 1 point. So we have 2 points from the respiratory, 1 from scale. From the oxygen saturation, we don't have, we didn't analyze this one, because we are not, you don't have below 87. That would be, you see, if you see below 83, 84 to 85, this is the third line, 86 to 87, and then you have 88 to 92, but this is on air. Or bigger on it. If you have more than 93 on air, this would be 0. okay? Because the others are on oxygen. If it's more than 93, 94, 95, this is on oxygen, so it would give 1 point, 2 points, 3 points. But we don't have no points here on this saturation, okay? The patient is on air. He is not using oxygen. So on air, it would be 0 points. So we continue having 0 points. We had 2 in the first, 1 in the second, 0 on the third, 0 on the fourth. And then we had the blood pressure on the fifth line. 1, 2, 3, 4, 5. On the fifth line, we have blood pressure that it was 100 systolic. So 100 would be 2. So we would have a 2 here. And then we have the pulse rate. It would be 112. The pulse rate, if we go again on the sixth line, we have it here, 111 to 130. It will be 2 points score. And then finally, well, not finally, is yet we have, when we are looking at the patient, if he is consciousness or not, we find that the patient is alert. So this will be 0 points. And then at the end, we have the temperature. The temperature, we said it was 36 grade Celsius. So if we go here to the score, we find in the last line, we find the temperature score 135.1 to 36. So this would be 1. So final score, 8. I think this is right. Any comments? Okay, lost temperature, no worries. Sorry, I didn't put, yeah, right. On the temperature, I didn't put grade Celsius, so that was my fault. So this is why you didn't add 1 point. That makes the score 8, right? So in the next slide, we will see what we have to do with the different scores when we have it. But I just wanted to point out here that we have, there are some methods to communicate, like this method that is the S-bar communication. I don't know if you know about it. Maybe some of you do, probably, for sure. This is called S-bar. And this is a nice way of communicating in a very concrete way with all the team. Here you have to explain the situation, background, the assessment, and the recommendations that you give about your patient. And you clearly get to your concerns this way in a very concrete way, and so it gets this information gets this way to the medical team. It's like also very helpful because you don't get lost in explaining other things of the patient, but you really get which is the situation, which is the background, which has been the assessment, and what do you recommend. So I mean, this is a transplanted patients that is well, the situation would be this patient has this vital signs. The background is that the patient is transplanted in actually is in myelosuppression, and it has febrile neutropenia. The assessment is the score that I have done in the early warning is 8, and the recommendation is we have to escalate to the emergency department due to this score. So it's an easy way, very concrete, to get to the information to the team. Just like we'll go through what we have to do in the different scores in this early warning score. Score 0, there's no change, so it's just the routine monitoring. In the low risk, there are some parameters slightly outside normal range. So the ward nurse should do prompt assessment and decide if she would increase the monitoring frequency or escalation of clinical care. If it's low to medium risk, score of 3, we have one specific physiological parameter insignificantly abnormal. So the action would be to urgently review by a doctor if we have to determine the cause and decide on the next steps. At a medium risk, the score would be 5 to 6, and then multiple parameters are significantly deranged. So the action will be to an urgent review by a acute care team, emergency to lead the decision to probably escalate to a critical care. And if you have a score 7 or more, the patient's condition is severe, so the emergency assessment is needed by a critical care team, and probably transfer the patient to a high dependency or intensive care unit. So I think nurses here, we can make the difference because we are bedside 24 hours, 7. We are aware of all changes, communicating with the patients, with the family. We have done this educational support for the family, so they will make us also aware. And we do all this emotional support on where are you, what's happening, how can we help, and what do you have to do. So this is really makes a difference, and it's important to be aware of all this. And I'm just going to show you this, but we're not going to go too much through it. Also to know that there is also a pediatric early warning score. It's called PEWS, and this is also based on some different things, than components than the use on behavior, neurological study, or cardiovascularly. We are going to see the capillary refill, which is a skin tone. For the respiratory components, we are going to check the respiratory rate and the oxygen saturation. Also, it's going to be based on the staff concerned. If the staff is concerned about what seeing that the child is not very well, and also on the family concern. So these are some not so objective things, but it's also important because they do give us a hint on what's happening. And then the vital signs should be evaluated, checking the ranges, because the ranges are going to be different for infants, for toddlers, or the older kids. And again, they also will have their warning score, and when the ranges of the score to escalate the needs of calling an emergency department, or doing more frequently detection of vital signs, or so on. So it's more or less the scale is going to be the same as in the adults. And well, finally, we've got to the end. So, oops, sorry, this went away. And just to share with you some take-home messages. Febrile neutropenia has a significant impact in morbidity and mortality in our transplanted patients. Nurse assessment and screening is key for patients with febrile neutropenia. We have to monitor them. We have to be aware and have the preventive measures. We have to do all this education around family and patients to get the best from them also, and to get the best for the patient. Treatment will begin after blood cultures and that have been taken, and within 1 hour of the onset of fever. This is very important to not escalate the worsening of our patient. And it's important to keep in mind that sepsis is life-threatening, and that early warning scores and structured communication method are key to escalate to critical care in advance, so we can prevent probably this life-threatening in the end issue. So thank you. You can contact me here at this email or anyway. We are also in the WhatsApp group, so with no problem we can contact. And thank you for attending.